Welcome back to Diabetic Foot Files. I'm Dr. G, and today we're going to talk about a tiny little tube that sometimes gets overused, sometimes blamed, sometimes praised, and misunderstood more than what it deserves. And I don't use it that often, but some people do. Today's episode about Mupirocin ointment. Sounds a little lame, right? But whatever because somewhere along the way, Mupirocin ointment does become the answer to some wounds, and some wounds that it probably wasn't even designed to treat. So, as wound care specialists, we see deep ulcers, exposed tendons, ischemic feet, osteomyelitis, but mm. So today we're going to talk about Mupirocin ointment, what it actually does, what it doesn't do, and why misuse is quietly creating a resistance to it and a false reassurance. Because some people do misuse it. Some people just prescribe it and be like Mupirocin ointment, and it's not the right ointment for that wound. So, what actually is Mupirocin ointment? So, Mupirocin, discovered in 1971, naturally derived antibiotic from Pseudomonas fluorescens. So, marketed originally as Bactroban. Okay, and it's one of the very few topical antibiotics that does not cross-react with cephalosporins, penicillins, or sulfas. And it has a very unique mechanism. Mupirocin inhibits the isoleucyl tRNA synthase, and you can hear that I'm tongue-tied with that one, blocking the bacterial protein synthesis so bacteria can't survive or replicate. So this mechanism is distinct from beta-lactams, macrolides, or fluoroquinolone. So clearly, with the unique mechanism, this is why mupirocin became famous. It has excellent activity against gram-positive organisms such as Staph aureus, MRSA, strepto, Streptococcus pyogenes, and and that's about it, in my opinion. So mupirocin does not treat gram-negative organism. It does not treat anaerobes. It does not treat biofilm, and it does not penetrate deep tissue. So how did it get popular? So mupirocin became popular because it worked when used correctly. So things like impetigo, minor skin infections, superficial abrasions, early infected nail borders, and most importantly, MRSA colonization. And that's where mupirocin shines. That's where it's like, yay, I get to show my talent off, right? But here's the problem. Somewhere along the way, we stopped matching the drug to the right wound and we just started matching the drug to convenience, which won't help at all. So here's the number one misconception that I believe they have about mupirocin ointment. Topical antibiotics do not treat deep infection. I'm going to say it again. Topical antibiotics do not treat deep infection. They do not reach to the bone. They do not reach to the tendon. They do not reach to the abscess cavities. And if pus is present, and if the wound is probing the bone, which is a positive, right? Positive probe the bone. And if there's an undermining or tracking, I can tell you right now, mupirocin is not the treatment on shouldn't be on the treatment plan for that one. Okay. You're just putting on decoration. So, when does mupirocin ointment make sense when it comes to diabetic foot care or a diabetic wound? Okay. Appropriate uses is like superficial skin breakdown. Let me say it again, superficial skin breakdown. And as you know, with the Wagner scale, we're going by depth, right? Like 0 is pre-ulcerative, 1, right? 2, full thickness, 3, remember, I always remember 3 is the bone because T2, yeah, yeah, bone. Okay, let me finish. Early infected callus after debridement, mild pyronychia. If you don't know pyronychia, it's like getting a mild ingrown, and small I wouldn't say even small shallow ulcers that have a confirmed gram-positive colonization, okay? Small ones, and only when there's also good perfusion, because I don't know why people love putting really the patient there was a patient that had all their wounds, they had critical limb ischemia, but all their wounds had I don't even know what it was. It was like a Vaseline type ointment that was making it more wet, more macerated, break down more. And also make sure that there's no deep structures exposed and no systemic signs of infection. So mupirocin is more of an adjunctive treatment option, not a definitive. So if you're using mupirocin as a main treatment, it's not going to be the best, and I think you lost the plot. So what does mupirocin don't do? So let's be crystal clear. Like I said, mupirocin does not break down the biofilm. Remember, biofilm is one of the biggest things that we have to deal with, especially with diabetic foot ulcers. It's like their little shield and guard. It creates them, makes it harder for the antibiotics to penetrate to kill them. Mupirocin does not improve perfusion. Does not. Mupirocin does not reduce pressure. Mupirocin does not fix the biomechanics. Mupirocin does not replace debridement, does not. And mupirocin does not replace antibiotics when needed. We're talking about IV or oral, okay? And it absolutely does not compensate for a delayed referral, okay? So putting a dry ischemic wound with mupirocin ointment is still going to be a ischemic wound, but it's going to be a moist ischemic wound, which we don't want. We want ischemic wounds to be dry and stable so that they can see vascular and get a full evaluation and see if revascularization is feasible to help the patient. So resistance. So let's talk about the part not I rarely hear about, but mupirocin resistance is real. Repeated use, long-term use, prophylactic use can create resistance, especially to MRSA, and we don't want that. And then when mupirocin stops working, we kind of lose one of our best topical weapons. So when you prescribe it in case, you're kind of like if you're using it prophylactically, okay, you have to use it in the right sense. Remember, superficial, only gram positive, things like MRSA, Pentago, things like that. But don't use it just in case. So let's make a quick real world scenario with this one. Patient comes in with a plantar ulcer, been treated for 6 weeks. Every visit, this patient has been getting mupirocin ointment, band-aid, and walking. There was no offloading, there was no vascular testing, there was no imaging, and the wound failed pretty much because the mupirocin didn't work, but also the patient didn't have the right tools, like the offloading, didn't get referred to vascular, and should have had imaging. So we should have done a full workup with that patient. So let's clean this up. This wound is a superficial colonization appropriate for topical therapy. So then you can try mupirocin ointment. Remember, superficial. If it's deep, no, don't. I wouldn't use it. Okay. If it's deep and it requires systemic management, no, no mupirocin. So what are the stuff that the boards want you to remember? Mupirocin, gram-positive coverage. Mupirocin has no gram-negative coverage. Mupirocin has no anaerobic coverage. Mupirocin is not for deep wounds. Mupirocin is not for ischemic wounds. And if you overuse mupirocin, you will create a resistance. So let's go through some quick questions because it is Sunday night and I still have things to do. So, mupirocin ointment inhibits bacterial growth by which mechanism? I'm just going to say it. Inhibits inhibit inhibit inhibits the isoleucine T RNA synthase. Okay? So mupirocin uniquely inhibits the isoleucine T RNA synthase, preventing bacterial protein synthesis. This mechanism explains its effectiveness against gram-positive organisms and limited cross-reaction. And forgive me, I guess I'm getting a little slap happy because I haven't been sleeping. I've been doing so much, I wouldn't say paperwork, but I have a lot of things that I need to get done. Which organism is most reliably covered by mupirocin? Is it A, Pseudomonas aeruginosa? Is it B, Bacteriolus fragilis? Is it C, methicillin-resistant Staphylococcus aureus? Or is it D, Candida albicans? The answer is C, methicillin-resistant Staphylococcus aureus, or MRSA. So mupirocin has a strong gram-positive coverage, particularly MRSA, making it useful for superficial skin infections and colonization. It has no activity against gram-negative bacteria, anaerobes, or fungi. Okay, which diabetic foot wound is most appropriate for mupirocin therapy? Is it A, a deep plantar ulcer with exposed bone? I think you already know. Absolutely not. Is it for B, a ischemic heel ulcer with dry gangrene? Absolutely not. C, is it for a superficial infected callus after sharp debridement? Or D, a chronic ulcer with a sinus tract infection? Absolutely not. So, just from the process of elimination, where we can say absolutely not, do not use mupirocin on this, the answer is superficial infected callus after sharp debridement. Okay, so remember, mupirocin is appropriate only for superficial, localized infections with gram-positive organisms. It should not be used in deep, ischemic, or chronic wounds with structural involvement. Next, which situation represents the misuse of mupirocin? Is it A, early paronychia? Is it B, impetigo? C, colonized surgical incision? Or D, osteomyelitis of the first metatarsal? The question again is misuse. Which situation is misuse of mupirocin? Okay, so think about the reasons to use it. We went through a few. So remember, it's not used for deep. So the only deep one that was in there is osteomyelitis of the first metatarsal. So topical antibiotics do not penetrate bone. So osteomyelitis requires systemic antibiotics and most often surgical intervention. So using mupirocin in a setting like this will delay definitive care. So do not use it on that. So, next question. Why is mupirocin ineffective against chronic wounds with biofilm? Is it A, because it's rapidly absorbed systemically? B, biofilm prevents topical penetration? C, it lacks activity against fungi? Or D, it causes tissue necrosis? The answer is B, because biofilm prevents topical penetration. So remember, biofilm is one of the biggest, what's it? Defenses a bacteria has, okay? And it's like it is the protective extracellular matrix that prevents topical agents like mupirocin from reaching the bacteria. So chronic wounds usually require debridement and biofilm disrupting strategies, okay? Next, which practice most increases mupirocin resistance? Is it A, short-term use for impetigo, C, culture-guided application, s- C, long-term prophylactic use, or D, use of MRSA colonization protocols? It's going to be C, long-term prophylactic use, because you're just using it just to guess and say possibly. So repeated, prolonged use of mupirocin, especially when there is no clear indication, will lead to mupirocin-resistant MRSA, so which will reduce its effectiveness in the future. So let's try not to do that. Next question. A diabetic patient presents with a non-healing plantar ulcer treated with mupirocin ointment for 6 weeks. The wound has not improved. You should have known that the wound is not improving by 4. Remember, if it's not decreased by 30 to 50% within the 4 weeks, you have to change your treatment plan. So it shouldn't have taken you 6 weeks. So what's the most appropriate step? Is it A, increase the frequency of mupirocin? B, switch to different topical antibiotic? C, evaluate perfusion, offloading, and depth? Or D, continue current treatment? I think everybody knows the answer to that. It's going to be C, evaluate perfusion, offloading, and depth. And this is something that should have been done on the very first visit, okay? Remember, failure to heal after 4 weeks suggests chronic wound pathology. First of all, like I said, vascular assessment should be on the number one plan protocol on your first visit, okay? Make sure, because when that patient follows up the next time, Did you see the vascular? And if they didn't, I'm going to call the vascular for you. Okay. Evaluate the biomechanics, evaluate the pressure points. Okay. Remember pressure mapping in your head. Okay. Next, which statement is appropriate regarding mupirocin use in diabetic foot ulcers? Is it A, it replaces systemic antibiotics? We already know that's not true. Is it B, it improves tissue perfusion? Absolutely not. C, is it treats superficial gram-positive infections only? Yes. And D says prevents amputation. So C, that's what it is. Okay, the most accurate use of it. Superficial gram-positive infection only. Like I said, mupirocin is a adjunctive therapy only. It does not address ischemia. It does not address the pressure. It doesn't address deep infection, and should not be ever relied on as a definitive treatment, in my opinion. Okay, quick question. A wound looks pink and clean, but continues to enlarge despite mupirocin ointment. What does this most likely indicate? Is it A, adequate healing response, B, resistance to mupirocin, C, underlying biomechanical and vascular problem, D, allergic reaction? So I know people want to say B, resistance to mupirocin, but remember, it looks pink and clean, okay? And it keeps on enlarging. So C is answer C because there's going to be an underlying biomechanical or vascular problem. So pink tissue does not equal healing. Remember, if it's getting larger and it's still pink, it suggests that there's something going on that's not being addressed fully. So either it's pressure, ischemia, structural imbalance, or just the treatment alone. Okay. Now, which phrase best reflects correct near-Puritan use? I think we're just going. This is the last one. Is it A, if it's open, add ointment? Is it B, topical antibiotics fix infection? Is it C, adjunct for superficial gram-positive infection? Or is it D, first-line therapy for diabetic foot ulcers? We already know that's absolutely not. But remember, boys like precise language. Mi precisión. So mupirocin is an adjunctive therapy, okay, treatment option, and only should be used appropriately for superficial gram-positive infected wounds. Superficial, okay? So in the end, mupirocin is not bad medicine, just that people have been overusing it, misusing it in some bad judgment. But if used correctly with precision, mupirocin is great. So in wound care, the answer is never what ointment should be used. The question is, why isn't this wound healing? Remember, it's always the question, why? Like, I love that movie, that show. What's it called? The Y Files? That's good, yeah. And this is Diabetic Foot Files, where we treat causes and wounds. And this is Dr. G. Take care of your feet because they take care of you.